Hey guys, am I audible? Am I visible? Hello, how are you doing? First of all, a very good evening. Can we have some interaction? So today we have started a series for second year students especially on how to write an exam paper. I think Anusha ma'am had a microbiology class yesterday. Today is mine and Siraj's class will be there very soon, right? Hi Arya, hi Arpan, how are you guys doing? So the agenda of this is very simple. We have learned everything conceptually in the entire pathology. Now we are going to make the last 2 months before your exam focused on only one goal, how to present an exam paper so that you can have a very good score, right? Because obviously always everyone wants to have a very good score after an year long effort. That's what we're going to do here. Good evening Karthik, good evening Blessing Hub, good evening DK, good evening Poster, good evening everyone, right? So I'm going to have one essay question. I'll tell you how to present an essay question, how to write each and everything in the essay question. Then we'll have a couple of short notes question. And also I think last year for you guys especially, they started the reasoning why question, right? In your anat, physio and biochem, you had reasoning why questions. I've included a little bit of reasoning why questions in pathology also, because I expect that they might change the pattern for farm patho micro to this year. If they change, we'll be ready for that as well, right? Before that, can we have some information from you guys? When is your exam? When is your final year exam? Final exam of second year? Have they told? Is the timetable out and everything? Ashish, not the right place. Come back in a year once you complete your NEET exam. We'll definitely learn medicine. Great, Arpan. I'll definitely put this today also. Today we'll be talking about the next chapter and we'll have the rest also very soon. When is your exam? Can I get September 1st? Okay, Arpan September 1st. So I think if September, if we work around July entire month, we should be able to finish the first revision of pathology. We'll be starting the second revision of pathology after maybe July end. So we'll be hopefully completing the entire revision of pathology by August, right? August first week or second week. If you're there in the WhatsApp group, I hope you will be in touch. I'll give you everyday portions on how to read, and also we'll have a little bit of question paper like thing for every day so that you get used to writing the exam paper, right? Great. So now let's start the discussion here. So this is going to be the question. Most of your long answers, LAQ questions, will be in the form of a clinical scenario, right? And then there'll be subdivisions. We have just created a random question with a few subdivisions. Can anyone tell me what is the answer here? Based on that, we'll definitely look at that. See, these subdivisions, some of them are related, some of them are totally not related to the question. We have kept that so that we'll know how to structure it. That's all. Okay, great. Can anyone tell me what's the answer here? What is the problem happening here? What's the cellular adaptation happening here? It's a very simple question. Because in a long answer question, in a scenario based question, you have to get the answer correct. If you get the answer correct, most of them are sorted. If you miss this answer, then the entire subdivisions might go wrong. Sometimes, especially in the second paper, when it's a systemic pathology or when there's a hematology question, you might sometimes struggle to find the right answer. In that case, please look at this option. Please look at them. You can sometimes reverse learn. Based on the subdivisions, you'll be able to predict what will be the answer be. This is only for tough questions where you don't know the answer. Come on, guys. I know this. I thought this is a very simple one. Can anyone tell what's the adaptation happening here? You guys have decided to keep quiet? No? Let's listen from you. Arpan, Blessing, Vandana, Imposter, Great Siddhi. Welcome back, Siddhi. Right? The metaplasia. Simple terms, metaplasia, but the exact one is squamous metaplasia here, right? So the question, the first part of the essay question is define the cellular adaptation in this patient and discuss the molecular mechanisms and its reversibility, right? In the reversibility sense, whether it's reversible or not, that's all, right? So now, when you write an exam paper, right, the first and the foremost thing is always keep a box or first two lines for the clinical context, right? So I want you to maybe, if you're comfortable, put a box. If you're great, something of the time. There's nothing but the data given there. It's a data given in the question, the clinical context of what is the answer, right? If it's let's say if it's a patient with an leukemia, obviously the age, clinical features, everything will make sense for us, right? So always keep a box for clinical context, which is nothing but the data points, which is there given in the question itself. So it's easy for me to start. Sometimes, most of the time, the starting is a problem, right? So The clinical context is simple. It's an age doesn't make sense much here, but the only thing makes sense for me is a smoker. 45-year-old fine, a smoker is there, and also the patient has a chronic productive cough. Okay, so I'm just taking the keywords from the question, that's all. Smoker with a chronic productive cough for 6 months is there, right? And the bronchial biopsy, whatever is there, I'm writing BX for biopsy, shows pseudostratified squamous columnar epithelium to squamous epithelium, right? So most likely the impression here, if it's a clinical diagnosis, write differential diagnosis or diagnosis. Since here I'm just going to get an impression, like Siddhi said and like most of you said, it's nothing but a squamous metaplasia. So this will tell the examiner he or she, the student, has actually processed what is there in the question and then given a thought through it and then arrived to the right answer. This is very, very important to create an impression. I'll just give you one more example. Let's say there's history of your CML. CML is one of the commonest questions which can come in the exam, right? I'll erase this later on. So if it's a history of CML, 45-year-old person with a massively enlarged spleen having a left hypochondrial pain, and CBC shows so and so finding, and the microscopy shows left shift and everything is there, right? All these are the classical findings of CML. So what I want in the clinical context in this case is an elderly person with a history such as of massively enlarged spleen. So that's how you always evaluate a patient. Then you have a CBC which says leukocytosis. Then your microscopy shows the neutrophilic shifts left. So considering all these points, my DD is CML. If you want to give one more diagnosis, use the term DD. If you want to give only one diagnosis, use the term diagnosis. Okay. Sometimes you might be stuck that it could be CML or something else. So in that instance, give a DD, but I would say most of your scenario-based questions, long answer questions are straightforward. In that case, directly write diagnosis, right? So we'll erase this, but this is how I want you to try the clinical context for every long answer question, which should be the first thing what the examiner should see, because there's no chance you'll make a mistake here. You're taking every point from the question and you're writing the diagnosis and the impression, right? Now, let's go to the subdivision, whatever has been asked. The question says clearly, define the change and also the molecular pathogenesis behind it. You guys easily completed saying it's metaplasia and stem cell programming, right? That's the right answer, right? But unfortunately, we have to write in the form of an exam paper, right? So by definition, you know the definition, right? Can anyone help me few keywords? There are few keywords which I expect in every question, every definition. What is that keyword you think is important for metaplasia? You might be right, you might be wrong, doesn't matter. Just give me one keyword which is required. You can go with the definition of Robbins, but I'm sure that we don't memorize things, but we know what is the context, right? So what keyword as an examiner you will expect in the term metaplasia? One, it's adaptation, right? Second, the most important thing, it changes from one mature adult cell type to another mature adult cell type. The mature and adult is very, very important. It's not an immature tissue. A mature squamous epithelium becomes a columnar. A mature columnar epithelium becomes a mature squamous. It will not become immature at all, right? Right? Perfect. It's one mature cell type becomes other mature cell type. The word mature is very, very important, right? So by definition, metaplasia is nothing but a reversible adaptive process. Every adaptation is reversible. It's just giving on extra emphasis on that. Okay. Where one adult mature cell type. See, I'm using the term cell type and not calling it an epithelium, because we know that we have epithelial as well as mesenchymal metaplasia, right? Becomes another adult cell type. Again, another mature adult cell type. And the most important thing, see, it has to complete. We had a starting, we had a mid, and it has to complete, right? You know many types of metaplasia. Can I say almost every metaplasia will almost always have a chronic stress or irritation as the cause? Okay, we'll end that also, right? Why it is changing, right? Because it's able to adapt better or withstand the chronic stress better. That's all, right? Other cell type that can withstand the chronic stress better than the initial one, which can, that's all is metaplasia. This has every information there. I have metaplasia, which is a reversible process. It's from one mature cell type to other mature cell type. Why I'm changing it? Because it's able to withstand the pressure better. In GERD, columnar can withstand it better. In squamous, in smoking, squamous can withstand it better, right? That's all. If you can write in one line or write in 2-3 line, I would prefer write in 2-3 line. Now, our question here is talking about squamous metaplasia, right? So when I talk about squamous metaplasia, it is always very, very good if I can have a pictorial answer. Most of the time, we know how to write a theory. Some of the students also ask like, how do I write and draw an image? Is image very essential? Image is very, very essential because it can convey more words than more what words can speak. Should it be beautiful? Not at all. I don't want a beautiful image at all. I want a descriptive and an explanatory image. That's it. We are talking about squamous metaplasia, and the context is very simple. From pseudostratified ciliated columnar epithelium, it has to become squamous epithelium. How do I draw it? See, I am not great in drawing. You know that, right? But you can easily, simply draw something which can make sense for the patient, for the teacher who's drawing it, right? One, every epithelium will have a basement membrane. So sorted. This is a pseudostratified ciliated columnar epithelium. So single line. What I'm going to do, it is pseudostratified. So you draw a nucleus here, you draw a nucleus here. That's what pseudostratification is. Done. Ciliated. That's it. You need not be amazing in drawing. It's just a descriptive image. Ciliated columnar epithelium pseudostratified. Because of the chronic irritation, here in our question, smoking. You can write it as smoking. It becomes squamous. The only thing which is unique about squamous is it's stratified. Again, I have the same basement membrane, right? It is stratified. So you draw one layer, you draw the second layer, you draw the third layer. That's it. If you want, you as and when you go above, it has to become flatter. That's how squamous becomes, right? Again, if you remember how squamous is, I'll have more nucleus here, I'll have more nucleus here. As it goes to top, it will not have nucleus. That's the polarity, right? Simple stratified squamous epithelium. So this conveys lots than a text. It's simple to draw. It will not take more than 5-10 seconds for you to draw one picture. Simple descriptive images which can convey much more than a text. Do try to draw them wherever possible. Do try to use the flowcharts wherever possible, right? So the question was simple. Define the cell adaptation and also discuss the molecular mechanism. We know for a fact it's simple stem cell programming, but that's a word. I need to define something so that it makes sense as a molecular mechanism. This is where your knowledge comes into play. When you write a question on metaplasia, don't think only from the general pathology metaplasia alone. We have read metaplasia, we have read dysplasia, we have read neoplasia, we have read almost everything required in pathology. Use everything here. Am I right in saying that GERD or smoking can cause cancer? It can. You know how it causes cancer, right? Because smoking causes persistent inflammation. Inflammation releases cytokines. Cytokines will cause mutations, alters the metabolites. That causes the change. That's what it's going to do. We didn't read them in metaplasia chapter, but we read them somewhere else. But same thing is going to happen here as well, right? So when I come to the molecular mechanism or any mechanism for that matter, every mechanism will have a step-by-step approach. It's always better if you draw a flowchart. Be it apoptosis mechanism, a flowchart is always better compared to a writing point-by-point writing, right? Anytime a flowchart is always better, right? So here, the molecular mechanism, I'm talking about squamous metaplasia. So what I'm going to say, the etiology. Etiology here is smoking. Or you can write any chronic irritation. So any chronic irritation for that matter is going to cause inflammation. Definitely, it will cause inflammation. So whenever inflammation is there, it is definitely going to increase your cytokines and your reactive oxygen species. If you want to elaborate them, but otherwise just write cytokines and reactive oxygen species. That's more than enough. right? And also it'll have some growth factors, mediators as well, right? Cytokines and reactoxin species. This cytokines and reactoxin species are the one which causes the stem cell programming, right? So here you can write that these cytokines can activate and alter the transcription factors of stem cells. Once it can activate and alter the transcription factors of stem cells, this can reprogram the stem cell. The ultimate gist is simple for me. I want this term. It will reprogram the stem cell. But I have to have a context how it can reprogram stem cell. Because you are in the fag end of your university exam, I need not just need the word. I need the entire process because you have read it somewhere. This reprogramming will convert them into forming stratified squamous epithelium. Wherever you want to stress a point in this entire flowchart, I want to stress in a point. That's the reprogramming of the stem cell because that's what the exam is going to look for. Put a box. You need not always change the color in the paper, right? Some people feel that I use many colors, I get more marks. It has to be highlighted. Whichever way is the best way for you to highlight, highlight. You use a box, you use a circle, or you change color, whatever you want, do it, but it has to stand out. The word reprogramming of the stem cell has to stand out because that's what every exam is going to look for, right? Done. So I need to know the entire pathogenesis here, right? Now, the last point in the question is also comment on the reversibility. That's what we saw, right? Is it reversible or irreversible? Come on, tell. Is it reversible or irreversible? Not a difficult question to ask. It is definitely reversible, right? It's 100% reversible. But should I stop with that? They said comment on the reversibility. Yes, it is reversible to some extent. Beyond that, it becomes definitely irreversible, right? So, end point, I will write that yes, metaplasia is a reversible process provided the stimulus is taken away. That is, smoking should be gone. Only when smoking is gone, it's reversible, right? Provided you remove the stimulus. It's not reversible as such, right? And also I want you to convey and complete it. See, why should the question of reversibility come in the first place? The only reason is there will be a path of irreversibility. That's what I'm concerned as a doctor. Reversible is fine. It will come back to normal, right? If the stimulus persists, they can change to metaplasia, can become dysplastic, can become neoplastic, right? Or can become cancer. That's the path of irreversibility. When they ask a question, don't stop with that. Add an extra point that will have a beautiful ending. When they ask a question on CML pathogenesis as a short answer, write the pathogens of CML. Please end with imatinib because you know the treatment. In microbiology, if they ask H. pylori, please end with 3-drug antibiotic regimen or 4-drug antibiotic regimen because you know pharmacology. Here onwards, it's not pathology, pharmacology, and microbiology. They are patients. If it's a totally theoretical one, that's fine completely. For a long answer, always have an ending. If it's a disease, have a treatment. If you're not sure about the treatment, just write lung cancer, surgery with chemotherapy. Enough. Something should be there as an end, right? It's not any more subject, it's about the patient, right? So this is the same thing what we know. I've just rephrased everything here, right? If you write one by one, this will occupy easily a page. I have the clinical context ready. I have the definition ready, a simple line diagram, a molecular mechanism, and also take on reversibility, right? That was the first question. We'll go back to the first question. This was a first question, right? It's good enough for you if you write this cleanly. It will not take time. And please understand, writing more pages is not equivalent to getting marks. You can write story when you don't know stuff. That is fine. I don't know anything. I need to fill up pages. But if you know the stuff, please be more crisper to the point. That's more than enough. You have one page for this, one page for this, one page for this. More than enough for an essay answer. Okay? Done. Now let's go to the second one. Tabulate the structural, microscopic, and kinetic difference between benign and malignant tumors. Now I want answers from you. My job is just to tell how to write it. That's it, right? Can anyone tell me the Differences between benign malignant tumors. I'm sure you can know. Whatever comes to your mind. The differences between benign malignant tumors. Tell everything, we'll just compile them. That's all. It's a simple table. You must have definitely read it in Robbins. Few words. We'll start. That'll be a starting point for us. Encapsulated benign. Benign does not metastasize. Great decay, great city. Come on, more. You guys know more. More than this, right? Well defined. Yes. Well defined for benign. Infiltrative for malignant. You have microscopy, no dysplasia, dysplastic features, pleomorphs and everything. It's there, right? Non-invasive, everything is there. Like I said, in an exam paper, always take the first point from the question. It's easy to write an exam paper. MCQ exams might be a bit difficult because I don't have anything in the question sometimes, right? Now look at the question. Tabulate the structural, microscopic, kinetic differences. So they've asked three main points and then divide, right? So when you have something like this, tabulate the differences on gross and microscopy. Tabulate the differences on treatment and prognosis. If they have already given what to tabulate, I want you to put three rows. Sorry, three columns, not two columns, right? One obviously for benign, right? And one obviously for malignant. You're going to tabulate. And please, when they ask tabulate, don't write a theory paper. Don't write a paragraph. They've told to tabulate. Just tabulate them, right? Here, I want you to write what they have asked to tabulate. Structural features, microscopic features, and your kinetic features. If there's anything extra, let's write. But I have to make sure I should complete whatever has been asked here, right? So I already got a structure on what to write for the question, right? So they asked to tabulate structural, microscopic, and kinetics. Structure is nothing but gross, whatever you guys said. Microscopic is microscopic. Kinetic is growth. In growth, your local behavior, your metastasis also will come into place, right? So these are three things that I'm going to use for, right? So here in benign, you know for a fact, benign is very well circumscribed, encapsulated, and they do not invade the surrounding tissue. That's all. They are well defined, encapsulated, and they do not invade surrounding tissue, right? So that's for benign. If possible, take scales. If there's a table, draw a neat table. That gives an extra brownie point. Fine. Malignant. Always they are poorly defined or poorly circumscribed or poorly encapsulated. Right? They will definitely infiltrate to surrounding tissue. What is important for me here is the keywords. Underline or highlight or put a box. But this has to be there. I need the examiner to divert to the keywords. Sometimes you know only one keyword. Rest everything will be fluff. You must have just beaten around the bush. I want them to see the keyword. So attract using the keyword. That's it, right? Infiltration is something which is a hallmark feature of malignancy. Everyone knows that, right? So if it's benign tumor for microscopy, right? I'll add one more page here because I wanted to do extra thing. Okay. So in benign, what do you think will be the microscopic finding for benign? Benign will not have anaplasia. Benign will not have dysplasia. But that doesn't make sense, no. I will write anaplasia present for malignant. But I need to write something for benign. So the easiest way I can write for benign is, can I say benign tumors are very well differentiated? Yes or no? What do you guys think? A benign tumor is lipoma. Is it very well differentiated? They are very well differentiated. Undoubtedly, they are very well differentiated, right? So I have to write that first. They are very well differentiated. Instead of writing well differentiated, you can write microscopically, cells resemble normal tissue. Lipoma will resemble a adipose tissue. Simple normal adipose tissue. Plus, they'll have a capsule, right? Plus plus or minus capsule, because there are some tumors which might not be capsulated. You know that for a fact, right? And then I can write the extra points because I need something to positive for benign than saying that they don't have mitosis, they don't have pleomorphism. So I need a positive statement for benign. Okay, benign resembles normal tissue with or without capsule, right? Then I can write, yes, benign tumors might have minimal pleomorphism. Benign tumors will have minimal mitosis or very few mitotic figures, and generally no necrosis. These are all negative findings for benign. So I need a positive finding for benign that it resembles normal parenchyma. Then I add extra points, right? Okay. Now for malignancy. Malignancy, we know the famous four. I have pleomorphism, high NC ratio, mitosis, and loss of polarity. There's no doubt in that, right? So we can write the same thing there, right? So malignant tumors in microscopy will have features of dysplasia. When I say features of dysplasia, see, it's depending on how big the question is. You can either lengthen it or shorten it. I can say that pleomorphism will be there. When I say pleomorphism, you can write here variation in the size and shape if time permits and if it has weightage. That's all. If it's a 2-mark question, I need not go and explain what is pleomorphism, right? So pleomorphism, they will have high NC ratio. They will have increase in mitosis or atypical mitosis. We won't forget these 4 words, right? And they will have loss of polarity. Okay, simple. So I know what is the features for malignancy, right? Like I said, it's always very, very important for me to emphasize in the form of drawing, in neat drawing, right? Not beautiful drawing. Again, it has to be meaningful drawing. That's all. No one expects you to draw amazing diagrams in an exam. Unless you are an artist, you won't be able to draw amazing diagrams in an exam, right? Most of us are not artists, right? So how do I convey to the teacher, okay, this is what benign is, this is what malignant is? For that, you have to, while writing this in the exam paper, keep in your mind what you're going to draw. I need one normal and abnormality known. The easiest one I can draw is an adenoma. Glands are very easy to draw. Squamous epithelium, I need to draw many, many linings. Gland, very easy to draw, right? So let's write here. I'm going to draw a difference between adenoma versus an adenocarcinoma. So you have to make sure, draw the easiest diagram, don't go with a difficult one. Squamous, multiple layers might become difficult. If you take sarcoma, again, many cells might make it difficult. Adenoma, simple 2-3 glands is enough for me, right? So here in adenoma, again, adenoma, it need not be capsulated. They are coming from the epithelium of the GIT, right? Simple. You can simply draw normal GI epithelium, put normal columnar epithelium, and then I'm going to have an adenomatous lesion, right? So adenoma also will have a simple normal lining and put tiny well-formed glands. Glands might have different sizes, but the most important thing is the nucleus, whatever you draw, should have normal polarity. It's going to come from a columnar epithelium, right? And the nucleus should always be in the base, a single nucleus. That's all is required. Okay. Just draw a single tiny blue dot. That should be enough for me. That's for an adenoma. That's all. More number of cells are there, more number of glands is there, and it's like a polyp which is protruding from the normal epithelium. You can write this as a normal epithelium. You can write it as a polypoidal adenoma. Polyp is nothing but protruding from the surface epithelium. That's all, right? A simple description for an adenoma. Adenocarcinoma. See, when the word carcinoma is there, I'm sure you know one word is very, very important for me. One finding is very, very important for me. That is invasion of the basement membrane, right? That has to be there. Before that, yes, obviously I require the pleomorphism. So I can draw a columnar epithelium here. I can draw a normal columnar epithelium here just to document that, okay, this is the normal with single basal nuclei. Then I have draw as ugly as possible. Irregular, I can have multiple tumor glands. You might draw big, small, ugly cells. You need not go and draw mitosis unless and until you are very comfortable with that. Just draw big blue cells. That's enough, right? And also, if you can mention, just put an arrow mark and say invading glands. Okay, and also you can say that if you want, you can write high NC ratio, right? They're just ugly looking glands, invading glands, high NC ratio. That's enough, right? So technically, I have written the same thing. I've explained the same thing. That's it. A benign lesion and a malignant lesion, as simple as that, right? So we know what to write for adenoma, what to write for adenocarcinoma, and the microscopy. Third is the kinetics. That's what they ask, right? Structural, microscopic, and kinetics. So in kinetics, just extend it. Kinetics is nothing but the growth behavior. That's all. How it's going to grow? It's going to invade locally. It's going to metastasize. All this will come under kinetic, right? Generally, benign tumors are slow growing tumors. They are expansive. They expand, but they don't infiltrate. They are expansive, but do not infiltrate and metastasize. Malignancies, they are rapidly growing tumors, but definitely they will invade and metastasize. Like I said, what is important for me is I need to underline or highlight whatever I want the examiner to see. That's about the kinetics of the tumor. That's it. Fine? As simple as that. This will tabulate all the differences. These are simple differences what you already know. But use the terms what the question is asking to start. So that's it's easy for you not to struggle where to start. You have already the starting point in the question. And try to draw diagrams wherever possible. It's the same, but drawing a diagram, a neat legible diagram will definitely attract the examiner, and obviously it will increase the page size as well, right? That's for the second part of the essay question, the difference between benign and malignant, right? Now, let's go to the third part of the essay question, which is outline the TNM features and explain what is tumor staging and grading, why it's required. Can anyone talk to me about TNM? I'm sure you know what is TNM. What is TNM staging? And what is staging and what is grading? And what is the importance of staging and grading? Anyone? Whatever you guys know. As usual, you said a few words. We just built it on the few words. That's all, right? T stands for the tumor size. N stands for the regional lymph node involvement. And M stands for the metastasis. That's what TNM stands for, right? That is staging. Grading is something which you look at the microscopy. So again, it's outlining one system. So I have to first write what is TNM and why TNM was first devised, right? So it's simple. TNM, it's a classification and staging system which is developed by a committee called as AJCC. You will learn about AJCC and everything when you go to final year. AJCC is American Joint Committee on Cancer, right? Develop AJCC to describe the anatomical extent of the tumor. This word is important. What is TNM? Rather than saying tumor node or metastasis, if I have a definition that's much more comfortable, this is important. It describes the anatomical extent of the tumor. How far it is, how big it is, and how far it is spread. That's all. If you can write AJCC, great. If you don't write AJCC, that also is great. Fine. Exactly right, facts teller. It's a much more refined word of what you said. It describes the anatomical extent of the tumor, how far it has grown, and whether it's spread or not, right? So in TNM, T, N, and M. T generally stands for the tumor size. If you know any TNM, give an example. Otherwise, there are few standard terms which I want you to know. I'll write them as well, right? Generally, if it's T0, there is no evidence of tumor. This is generally used when I do chemotherapy and after that. I don't see a tumor at all, but there was a cancer before. T0 is no evidence of tumor. TIS, this is common for every cancer. TIS stands for carcinoma in situ. ISS in situ. That's all. This is common for every cancer. Then just write T1 to T4. You need not write what's T1 to T4. That differs for any cancer. Like breast cancer might have 2 to 5 centimeter. Colonic cancer might have invasion to muscularis and everything, right? But T0 and TS is common for everything. Same way, I have N for the regional lymph nodes. The term region is very, very important. This is regional nodal spread. Okay, it is regional nodal spread. Fine. What is N0 stands for no metastasis in the regional nodes. N1, N2, N3 based on different tumors, it will differ, right? So again, N0 stands for no nodal metastasis. Then I have N1 to N3 based on systems, based on spread. N1 might be one lymph node, N2 might be multiple, N3 might be going to other than regional, right? So again, it differs based on cancer to cancer, ignore that, right? Then M. M is distant metastasis. It's also metastasis, but it's not regional lymph node. It is distant metastasis. Here, for me, M0, there is no distant metastasis. Here there's only one. Across the tumors, it's either M0 or M1. M1, distant metastasis present. When I say distant, you can also write in brackets if required to lung, to liver, to brain, right? Two different organs in the body. Not if it's a breast, not going to the axilla or skin. That is not distant. Going to the brain is distant. Going to the lungs is distant, right? Going to some other place like liver is distant, right? So you can write in brackets, the tumor is spread to lungs or brain or liver. The reason why I use this three organ system is, you know for a fact, in these three organ systems, mets are more common than the primary, right? You know that. That's why I use these three organ systems. That is comfortable. They'll have more distant metastasis. Fine. Okay, that's grading, Sthi. Great. Fine. So that's for TNM, right? That's what TNM classification is. Actually, if you want to score extra point, you will learn this again when you go to your final year. Apart from TNM, there is one more thing beyond TNM, which is called a staging of tumor. TNM is just TNM classification, right? So there is the question is on staging of tumor. Staging is not actually TNM. Staging is considering all things. Considering all the three parameters of T, N, and M, we give 4 stages for tumor, right? This is nothing but a combination of T, N, and M. Like for example, I'm just giving for example, T1, N0, M0, stage 1. Okay. Generally, stage 1 of a tumor is this example, not always for every cancer. T1, N0, M0. That's stage 1. Generally, stage 1 tumors are localized. Breast cancer, only there, stage 1. Okay. Then I have stage 2. Stage 2 are locally advanced tumors. Might be a little bit bigger, or N1 lymph node is involved. Something of that sort, right? Could be again T2 or T3, N0, or it could be even T1 with N1 or T2 with N1. One node is involved. So it is locally advanced tumor. It's there. It's locally advanced. Fine. Stage 3 tumors. This is what actually is staging, right? It can be different permutation combination. I am not going for that. More than N1, N2 stage 3. But the only thing in here most important is M will always be 0 here. It's not distant. Here I might have N1 or N2 and any T staging, right? These are advanced regionally. See, when I say locally, it's in the breast parenchyma. Region, breast and axilla. That is regionally advanced tumor, right? These are generally regionally advanced tumor. Stage 4 is the worst of all. Stage 4 is your anything with M. Any T, any N, if M is there, if distant meta is there, it's stage 4, and stage 4 is advanced stage. Okay, so this is what staging is. T and M are parameters for staging. Okay, hi Achita. These are parameters for staging. I combine them and use staging. This stage 1, 2, 3, 4 will differ for every cancer based on the type of cancer, right? This is just a template, that's all, right? This is what staging is. The next question was, what is grading? Grading, as Siddhi already said, grading is It's a microscopic terminology which tells how closely the tumor cells resemble the tissue or cell of origin, right? The tumor resembles the parent tissue. You can either draw a diagram or you can explain it with the help of theory. Drawing a diagram is easy. Again, go with same glandular malignancy. Well-formed glands, grade 1. Glands in solid area, grade 2. Completely solid area, grade 3, right? So if we go with adenocarcinoma, I can put one image of completely well-formed glands resembling the normal thing. I call it grade 1 tumor. I can have half glands and half solid area, and I can call grade 2 tumor. You can draw this as solid area. You can say it is glandular. And I have third grade tumor where it is completely solid. There are no glands at all. That is grade 3 tumor. For an adenocarcinoma, it is very simple and explanatory, right? So I have glands, very well defined. Glands and solid, not that differentiated. Completely solid, completely gone. Right? Higher the grade, bad, more worse the prognosis. That's it. Fine. Okay. That's, in other words, it's a degree of differentiation, right? So we know about TNM staging as well. It's a simple single long answer question. Always before writing a long answer or a short answer, think for 3-4 minutes, maybe a few seconds, 10-15 seconds. Your brain is very, very fast. When you think, I don't want you to think, okay, it's a question on metaplasia, I will think and write only from the first chapter. No, you learned a lot. You know a lot. You know, not just, sometimes you might write an answer from some points in physiology and anatomy also. That's completely fine. The first 15 seconds of your thinking is going to tell you how I'm going to formulate the answer sheet, right? Based on that, we can easily go through it. We know what is metaplasia. We know how to write the clinical contest, draw a diagram, draw flow charts, TNM, so a table. We know how we started the table. We started from the question, what they're asking. We did the same thing. Our knowledge, whatever is that, we divided that. Then we know the TNM staging and classification as well, right? Okay, that's how I want to present for essay. 3-4 pages is more than enough for essay. If you know more, great. But if more lesser you write, more happy the examiner will be, because they have to correct and read all through your stories, right? Okay, perfect. Now let's go to the next question. A 5 mark. We'll just see how to present a 5 mark, and we'll also look at few reasoning way questions as well. Fine. Okay, perfect. This is something which can commonly come. Can anyone give me inputs on this? If you give this is a very common question, I know by this time you must have revised inflammation chapter if you're in the WhatsApp group, and if you revised, tell me what this is. I'll just give you on how to draw and how to present. That's it. Discuss the role on arachidonic acid metabolites. How will you start with? We'll see how to start, because starting will decide everything for us. Will you start with like this? What is there in Robbins, arachidonic acid, Cox, logs, or you want some other way to start with? Every question should have a head, should have 1 or 2 lines at the starting. Only then you should go and draw a flowchart. Just don't jump into a flowchart, right? That's not how it's structured, right? Discuss the role on arachidonic acid metabolites. Everyone knows that. Yes, arachidonic acid metabolites is going to use the phospholipase A2 and create everything, right? Rather than writing like that, let's start with what is arachidonic acid. Can anyone tell me where does arachidonic acid come from? You guys know that. Where does arachidonic acid come from? Anyone? It's going to come from the cell membrane, right? Can I say cell membrane is nothing but fat? Yes. This is also a polyunsaturated fatty acid, arachidonic acid, that's all. It's a membrane phospholipid stored there, right? So the origin of arachidonic acid, where I'm going to start the question with, right? Arachidonic acid is a, if you can write polyunsaturated fatty acid, right? Otherwise, just write a fatty acid derived from the membrane phospholipids. I'm writing PL for phospholipids of the inflammatory WBCs or the injured cell at the site of inflammation? We know that cell necrosis will have free phospholipids, right? So this is where I'm going to start with. We all know what is arachidonic acid, but you have to think for a few seconds so that you can start with a single or two line rather than starting in the form of a table, right? That's it. Perfect. So it's a membrane phospholipid. Fatty acid from the membrane phospholipid that's there from the WBC or the injured cell at the site of inflammation. As simple as that, right? Then you can write whatever you know, right? You definitely know an entire flowcharts of arachidonic acid, right? So what's the first enzyme involved in the arachidonic acid pathway? Anyone? The first enzyme involved in the arachidonic acid pathway. From the membrane phospholipids, you have the phospholipase A2. Phospholipase A2 will give you arachidonic acid, right? The moment you have the arachidonic acid, what's the next one? You will have to write the COX and the LOX pathway. Whatever you know, write the entire thing. We will start it. So you have the membrane phospholipids. If you remember, Robbins will have an image like this for membrane phospholipids, the phospholipid bilayer, right? That's where your arachidonic acid is going to come with the help of the enzyme phospholipase A2. These enzymes should be put in the form of a table or a different color or highlight, because these enzymes are the most important thing in the entire arachidonic acid pathway, because we can block them. We'll have to write that as well, right? From this, we have the phospholipase A2, which will give me the arachidonic acid, right? That's what is going to give me the arachidonic acid. If you look at Robbins will have two big flowchart and an entire table, right? It's difficult for us to draw two big things in a paper in an exam. So what I want you to do is at some point stop and take it into two different pathways. Arachidonic acid comes from arachidonic acid. I do have two pathways. One is your lipooxygenase pathway, and the other is cyclooxygenase pathway. You can write COX or LOX also. Then stop it there. Don't keep drawing like leukotrienes, prostaglandins here, because your exam paper will become cluttered. Robbins, it's congested. It's drawn diagram, right? We cannot do that, right? Then write COX separately and lipooxygenase separately, right? Then I'll talk about COX pathway separately. So again, I am starting a heading. Every heading should have one or two lines. Then only you have to go to the flowcharts. What's line here? We have two COX. That's a very important thing, right? I have constitutive enzyme and I have inducible enzyme, right? Cyclooxygenase have COX1, which is constitutive enzyme involved in physiology. In the normal physiology, and also have COX2, which is an inducible COX during inflammation. COX is the cyclooxygenase, right? So then we'll take it from there. From the arachidonic acid, it also same starts the arachidonic acid. The COX enzyme acts, COX1 or 2 doesn't matter. Then it gives me multiple subpathway. Here it is your choice. If you want to write prostaglandin H2, G2, those are intermediates. If you want to write them. Otherwise, just go to the required thing, right? The required thing is for you ultimately your prostaglandin E2, D2, I2 and thromboxane, right? If you want, write that. I do have intermediates PGG2, PGH2. These are intermediates, does not make any sense for us, not useful for us. They're just intermediates. Then we have important guys. I want to divide into three things: PGI2, thromboxane A2, because these both are opposites, and we have PGD2 and PGE2. More or less same. I'm not saying exactly same, more or less definitely same, right? PGI2 has one more name that's must for it, right? We have prostacyclins, right? Prostacyclin will, what will they do? They'll cause vasodilatation or constriction. They'll cause vasodilatation. I told an easy way to remember, thromboxane A2. It's going to involve in thrombosis. If it's going to involve in thrombosis, it should cause constriction. Something related to that, right? So this will cause vasoconstriction and thrombosis. It will increase platelet aggregation. And your prostacyclin is exactly opposite of that, right? It will cause vasodilation and it will reduce platelet aggregation. And we know D2 and E2 does the same thing what the acute inflammation does. It's vasodilatation, increase in vascular permeability. Fine, that's it. It's vasodilatation and increase in vascular permeability. Do write in brackets, PGE2 is one of the main thing which is involved in the fever. D2 has a little bit of chemotactic factor. This is in addition to whatever the other prostaglandin does, right? So this will be your COX pathway, the cyclooxygenase pathway. Then comes your lipoxygenase pathway. Fine. Again, for lipoxygenase pathway, if needed, write the intermediary. Otherwise, ignore the intermediary. Fine. The lipoxygenase has 5-HPT. There are quite a few intermediates, like 5-HPETE, then 5-HPE, multiple things come, right? So arachidonic acid, from arachidonic acid, we have the lipoxygenase. The first one is the 5-lipoxygenase. Okay. Number 5 comes first, so think as 5 as the first one, right? 5 gives an intermediary called as 5-HPETE. Okay, if required, write this, otherwise just say it's an intermediate. From this intermediate, I'll have your 12, bigger number comes second, 12 lipoxygenase, and then again this 5-HPET only will disintegrate into leukotriene A4. Okay, leukotriene A4 again is an intermediate, it will not give rise to anything. Then it has leukotriene B4 and leukotriene C4, D4, E4, and then it gives LTB4. Fine. The 12 lipoxygenase pathway gives lipoxins. Lipoxins are anti-inflammatory, right? They also have A4, they also have B4. Okay. C4, D4, E4, you know, they are also called as slow reacting substance of anaphylaxis. So they'll have two important things, bronchospasm and increase in vascular permeability. LTB4 is one of the most important, most powerful chemotactic agent. Okay, these are anti-inflammatory. Okay, as simple as that. Fine, simple. Like I said, since you are the fag end of the exam, don't stop with this. Please write, is there any way I can modify it? Right, so modification, either you can put in the form of the table only. In the table only you can write that. You can stop leukotrienes by saying that, okay, leukotrienes are there. I can use drugs like montelukast, which are leukotriene antagonists, receptor antagonists, which can help here. I can try here aspirin, NSAIDs, which can block them. Or I can try here steroids, which can block the bigger guy at the start itself. That will stop your phospholipase A2 itself, right? So these are anti-inflammatory actions. Though they asked only the prostaglandin or only the arachidonic acid metabolites, it's our job to have a clinical application to everything, because you know it, just show it off. That's it. Fine. That's about how to write a simple short note. Fine. Okay. Now, I just want to take a little bit of time. There are a few more questions. I will give you the answer for it in the PDF. I'll share it in the WhatsApp group. I just want to have few reasoning why questions. Okay. I have 3 reasoning why questions. Why a single gene mutation produces disease only in some individuals, but it remains clinically silent in others, right? Because I feel that you might have this in second year also. I have one more. Why do malignant tumors invade and metastasize, but benign tumors remain localized? Okay. And why does loss of cell tolerance lead to autoimmune diseases despite immune system normally protects the body, right? There are 3 reasoning why questions. I hope you know the answers for all of them. We are just going to structure them. Can anyone tell me what's the answer for this? It's just a reasoning why question. Why? There are lots of answers for this. If you write even one, that is enough for me. Why can a single gene mutation produce disease in some individuals but clinically silent in some other individuals? Can anyone define this? Can anyone define it? You know the whatever comes to mind. Siddhi, Fahim, AK, Archita, anyone who's online. What's the answer? Okay, I'll give you a clue. One of the features of autosomal dominant disorder is this. Nuts and Hewitt hypothesis will be only with respect to cancer, right, Siddhi? Not every other mutation. With cancer, yes. The answer is simple. For this, the answer should come from your first year, biochemistry, or even from your school days. Gene does not function as gene. A gene's function is dependent on genetic, epigenetic, and environmental factors. A gene does not express if there's no environment there for you, right? Your parents might be superb intelligent, but if don't give you anything to read, I'm going to put you in a forest. You might not express as much intelligence your genes possess, right? So the simple answer to this is genes function is based on multiple factors, based on epigenetics, right? Environmental, and many more, but these two should be the most important one, right? Epigenetic factor, environmental factors. It's not just the gene, right? For example, you must have definitely read this. We did read about something called an incomplete penetrance in autosomal dominant disorder, right? That's what actually the question is. Gene is having a disease in some, complete penetrance in some, but remains clinically silent in others, right? Because it's penetrance, right? So, best example for us is autosomal dominant disorders with incomplete penetrance. This is a very, very common thing which most of your examiners, everyone must have heard it, they must have known, right? There's nothing, penetrance of a disease is nothing but the extent to which a mutation can cause a disease. But why is the penetrance the question, right? Again, given subdivision example there. If a structural mutation, in my lectures I might have given an example for this, which helps to sprint, there'll be no symptoms if the individual is not a sprinter. As simple as that, right? If there's a mutation which helps in sprinting, there'll be no problem at all if the individual is not a sprinter. It's environment, right? That's all. I gave one more example also. If it's going to affect learning, it will not be helpful for a person who's going to run, right? It's going to be helpful for, it will affect more if you're a doctor, if you're going to use lots of memory and related things, right? So as simple as that, it's a simple environmental factor. That's one of the examples, right? The other example is epigenetic modification. Please do write them as well. Second example, the DNA methylation and or acetylation, which are epigenetic modification, can control genes expression. So this also is a reason why I do have a mutation, but sometimes I don't have a disease. There are lots of things. I'll put in the notes which I'll give to you, lots of them. But these two are something which a doctor should know and you should be able to write. For a reasoning by question, I'll be more than happy if you write this, because the genes function is based on epigenetic factors, based on environmental factors, not just the genes mutation alone. That should be more than enough. But you can explain, it will be great. Fine. Okay. Next. Anyone? It's a simple reason. Why do malignant tumors invade and metastasize while benign tumors remain localized? Anyone? There are two important things here. If you say that two important things, that should be more than enough. But like I said, there are multiple reasons for everything. Why do malignant tumors can invade and metastasize while benign tumors remain localized? The simplest answer to this is malignant tumors, or malignancy for that matter, undergoes lots of mutational changes during the course of the disease. We call them passenger mutations, right? Right? They acquire new mutations during the course of the disease. Okay? And this is something which is very, very important, which gives them the metastatic potential. Not capsulate is one of them, that's all, right? So what are the new mutations? Two important things, like I said, which is very important. One is lack of cell addition, the E-cadherin loss. That's very, very important, right? So it, yes, it invades. In addition to that, they'll have loss of cell addition. And not just that, they also have genes which is going to destroy the stroma or extracellular matrix. Okay, these are just new mutations. Because of acquiring new mutations, they tend to spread. Benign tumors is very well encapsulated. Benign tumors, they don't lose the addition. They'll always be like a mass. They won't go outside, right? They don't have much proliferating capacity. They don't have angiogenesis. All these are negative pointers. But I have to say why a malignant tumors can metastasize. Because they acquire new mutations in the course of the disease, which we call them passenger mutations. That's the reason they are able to spread, and a benign tumor, which is confined, will not be able to spread. Got it? Perfect. Great. Okay. The next one. Why does loss of cell tolerance lead to autoimmune disorder despite the immune system being normally protecting the body? For this, I have to give a, see, this is actually the statement. That's the reason. Loss of self-tolerance is the reason. For that, we have to tell about what's normally self-tolerance, then what will happen if self-tolerance is lost, and that's the reason my body is going to recognize my own antigen as foreign, right? As simple as that, right? So for this, you write, what is tolerance? Tolerance is nothing but a mechanism to differentiate self and non-self. We do divide them into central tolerance and also peripheral tolerance. Okay, so it's simple. So because of any errors which affects tolerance, for example, you know a few examples for sure. Example, there's a mutation in CTLA4, because CTLA4 mutation is very, very important for energy, right? CTLA4 mutation normally helps in peripheral tolerance in a mechanism called as energy. I hope you remember the CTLA4 PD1 is the one which will go and block the co-stimulatory molecules, right? So when there's a CTLA4 mutation, what will happen in mutated CTLA4? When T cells bind to self antigen, the simplest example is the co-stimulatory molecules will not be blocked. Are not blocked by the CTLA4 because it's mutated. So this will result in activation against self antigen. So tolerance is a mechanism by which I stop it. So when I have mutations in genes affecting the tolerance, it's not going to stop, and it's going to consider my self protein also as foreign. That goes and destroys the cells, right? That's as simple as your self tolerance and why evading is going to cause problem, right? So try to give a gist in one line, and then if possible explain it, because I feel that reasoning why it's a very good move by an MC. It will not just make you think differently. It'll also help you to study like that. If all 4 years has reasoning why, that'll help you lots and lots in your NEET PG INST like exams. Not just that, when also you go to practice, you have to reason each and everything. Only then when you go reason, learn and apply everything in future, you'll be able to see more and better patients. Fine. Okay. I'll do one thing. What I'll do is I won't give this writing of mine. That will be there in the PW group. In your WhatsApp group, I'll put you a PDF, right? So created obviously by ChatGPT on a way to much more presentable way, because my handwriting is not that great. Fine. Okay. Any doubt? Do let me know.